Welcome, friends. I would be presenting today MPFL reconstruction, a simple reproducible technique. And in these times, I think this is the best way we can do our education online. So, as we know that MPFL is primary medial restraint of patella in cases where we have a lax patella syndrome or we have lateral dislocation or recurrent dislocation of patella. So MPFL, if it is gone, it's a band of tissue which extends from the proximal proximal part of the patella, leaving about 10 to 12% of patella proximally, and goes up to the middle distal third of the patella almost, and leaves about 30% of patella at the lower end. It's a broad band of tissue which goes and condenses and attaches somewhere between the adductor tubercle and between the medial epicondyle. And this tissue kind of forms a check ring which lets patella remain in its place when it tracks. So as you can see, I will straight away go to the dysplasia of this MPF, the femoral condyles. There are four grades which have been described on the lateral view. The grade A dysplasia, which is the crossing sign where there is a mild trochlear dysplasia on the lateral aspect. Then there is evidence of crossing sign and there is a spur, as you can see on the this diagram. These are book diagrams. So this spur shows that there is more dysplasia and you can see a part of medial condyle coming up. And then there is a crossing sign. There is a double arrow, a double contour dysplasia, which is dysplasia of crossing sign and the arrow. And then there is the grade 4 dysplasia where you have concomitant presence of crossing sign and the supratrochlear spur, a double contour sign, as you can see. And you can clearly see here that the dysplasia here, you can see almost a good contour of femur anteriorly. And here you can see there is absolutely. So probably this grade and this grade are two grades where you would be thinking of some other procedure rather than just doing an MPFL reconstruction in most of the cases. As you can see, representative diagrams, probably this is the best place where you can do a MPFL recon. This is you can try and it is successful in 70% cases. But these two definite no-nos, you need to go for some femoral procedure or something else. So here, I'll quickly move on to certain things which you need to know. This is the sulcus angle. The shallower the angle, the more the chances of this patella to dislocate on the lateral side. This is the TTTG distance calculation. As you can see, this is the trochlear, the line through the middle of the trochlea. This is through the tibial tuberosity. And the distance between these two is the TTTG distance, which ideally should be less than 2, but the threshold of operating for various surgeons is different. And therefore, you might have a TTTG distance of 2.3, 2.4, and some surgeons would still do an MPFL, while in a TTTG distance of more than 2.5, definitely I will not do as only MPFL. I would combine it with some other procedure. Here, there is another MRI-based calculation, which is the lateral trochlear inclination. And here, if it is more than 11 degrees, it is supposed to be safe, and less than 11 degrees is supposed to be higher chances of dislocation of patella, and therefore you have more shallow, the trochlear groove and the chances of dislocation. On the other hand, after reconstruction of MPFL, if you have a higher LT, very high LTI, the chances of the pain in the retropatellar area is high. So isolated medial patellofemoral ligament, what do you need to do a reconstruction? You basically need a right patient. As I said, the criteria of finding out radiologically which your best patient is, type A and some of type B. You need only one graft. Most of the times, if you are doing it with a graft, there are several techniques described, but I usually use a SEMITI or a gracilis graft. You need reproducible landmarks, which you as a surgeon can find, not depending on too much of a lavaloo. And you need adequate average skill set, like a surgeon like me. Anybody can do this surgery. It is not something very out of the world. What kind of implant do you need? Well, there are several literatures described: bioscrews, anchors, fiber tapes, swivel lock, special implants. But I use a very simple technique. It's a very common technique also. Let me clarify this. It is done with simple one endo button. So this is the patient where you can see in the cuts, relevant cuts in that CT scan, where you can see there is a tilt of patella as if it is ready to dislocate. And here are those two lines which are important, where you see it's not just the trochlear groove, but you need to understand if there is a patella alta, it will slide over the lateral femoral cortex very easily, because the patella alta itself needs to be corrected, and that's a different situation altogether. So in this patient, as you can see, there is no patella alta. The insult salvati ratio is 1.2, and CD ratio also is 1.2 or less. And the ID ratio, insult salvati ratio, should not be more than, it should be between zero 0.8 and 1.2. And CD ratio, which is the line here from the tip of the patella to the base of patella, and from the base of patella to the proximal edge of the tibial condyle, this should be less than 1.2. And if that is so, then therefore there is no patella alta, and you can safely understand that it is primarily because of the medial restraint plus minus trochlear groove issue, where you are dealing with, and you don't really need to deal with patella abnormality, and you can go ahead with your MPFL, which is there in this case. And you can see this skyline view of this patient, how much the patella is opening up. Here, the patient's TTTG ratio is being shown. This is the patient which we are operating. The TTTG ratio is less than 2.3 centimeters, which is 23 centimeters. My threshold to do surgery with isolated MPFL without any associated abnormalities in this case is okay. So therefore, I have done a primary MPFL for the restraint. This is a standard cut to see whether there is any patellofemoral issue. Here you can see that there is a recurrent dislocation of patella leading to a chondral injury also, which needs to be probably dealt with, which we will see, which I did just a shaving. So here, friends, is the video where we start the surgery. While doing this surgery, first of all, we assess how much the patella easily is going out. It will dislocate once we flex, but generally it kind of goes into, and inside the joint, we must see in these two videos how much the patella is going up. So in the middle movie, you can see we need to first clean all the chondral tissue which is there between, which is from the patella. And once it is cleaned on the lateral side, you can see how much the patella is opening up as you bend the knee on the lateral side. So the patella kind of opens up as you bend the knee, and there's a lot of space disparity between the medial and the lateral side, and the patella does not track properly, as you can see. Once you've done this, I have taken the graft of SEMI-T already. I usually take only one single graft. I have taken SEMI-T in this case, which is a long graft, and the double length of SEMI-T, after doubling, it was about, the thickness was more than around 9 millimeters. So that means 4.5 millimeter strand thickness of the graft was there. While doing this surgery, this is a very, very important step, the type you take the incision. Once you take the incision in this surgery, the most important aspect of taking this incision is to develop a plane after this. Now, if you do not develop a right plane, this whole surgery becomes intra-articular. Sometimes while developing the plane, you might find that actually this plane is between the fascia and the muscle. So therefore, you have to develop this plane very carefully. Sometimes you end up entering or puncturing the joint, but initially you might have those issues, as you can see in this video. Sometimes it happens in the best of the hands also. But what happens is that if you are doing this surgery, and if you do have inadvertent kind of hole into the suprapatellar pouch, it doesn't really matter. You still go on developing the carefully developing this incision, and try to develop a plane in between with a blunt artery forceps, as you can see. So sometimes the joint fluid does come out. You don't need to worry about this, but you should avoid an injury like this. This is a very nice illustration. And in case you have this, you really don't need to worry too much. Still, you keep developing the right plane which you need to develop. Try to get the right hemostat into the tissue, as you can see, as it is going down. And you try to approach a point which we have already made here in order to kind of reach there below and try to come out from that point, which is at the medial epicondyle at this point of time, as we have marked. And after that, once we do that, we kind of go to the next step. In this step, we take the patella and we drill our hole of approximately 1/4 from the proximal pole of patella. And this hole is done with a bead pin from the medial to the lateral side. Once this hole is developed from medial to lateral side, this I am using a bead pin which we use for passing the sutures. And after this bead pin, which is a 2.7 to 2 millimeter bead pin, we usually over drill it with, if the graft is thick like the one which I have taken in this case, which is 4.5 millimeter graft, we have to use a 4 millimeter or 4.5 millimeter drill, which is for drilling, over drilling this particular. And then the next step is to retro drill from the other side with another bead pin. Now this again has to be about 1/3 from the lower pole of patella. And once you do that, the thickness of most of the patella, this is a short lady, thin lady, and still in this case also the thickness of patella was quite adequate. You can leave about 4 millimeter, 3 millimeter up and down both sides and save the cartilage very easily. Now here you can see we are over drilling the patella proximal bead pin. Similarly, you over drill the distal bead pin, and approximately 4.5 millimeter of drill hole was done in this case. In case your graft is very thin and you find that after doubling the graft, you have about 7 millimeter thickness, then you are at an advantage and you can actually drill with a 3.5 millimeter drill bit straight away. And that will give you very easy access and a thinner hole. But in case a graft is thick, like the one which I took in this case, you minimum need a 4.5 millimeter hole. Most of the patellas are very accommodative. You have to stay in the right plane and you have to measure it well. And it can be very forgiving also. So once you have done this, you go ahead and do the drilling on both the sides up and down. And then after doing that drilling, your holes are ready for passage of the graft. So now you take the graft which you have already whip stitched on both the sides, and you pass it into the bead pin, and you just have to pull it first through the proximal hole. After pulling it through the proximal hole like one you can see here, and this is getting pulled out through the proximal hole very nicely. It is a bit good to have a bit of struggle. Remember that if it comes out very easily, it is a very, very thin graft. You need to actually struggle and pull it out. This is the time when you are testing your graft and you're looking, it comes out very snugly. And the more snug it is, the happier you should be. Similarly, you pass the other end of the thread through the bead pin on the other side, and then you take it out, as you can see on the lower end, and take the graft out. Here also you can see that we were struggling, and after struggling and pulling it out, it takes some time, but it is better. Again, I always say you struggle now than struggle later with a loose graft. So once you have taken out these two ends, you can see very nicely both are together, and you already have your check ring. Now, where do you put in the check ring? You put in the check ring at, try to put in at an isometric attachment point of the MPFL. Well, there are various ways to see it. I use a very simple technique. I had shown you that cross mark which I put at medial epicondyle, where I make my incision. And this cross mark guides me, and I make digitally palpate adductor tubercle and medial epicondyle and go between 2/3, 1/3 area, and that is my isometric MPFL attachment point. Now that I intraoperatively decide, but there are various ways of actually more localizing that point. As you can see in this C-arm image, you can take these two lines which are running parallel to the condyles, and you can take a line which runs parallel to the shaft of femur, and the place where these two perpendiculars meet this line, uh, approximate place is marked here. And this is, if you are 9 millimeter within this area, you are okay as far as the isometry of the MPFL is concerned. The shuttle insertion point is a similar type of point. It's a tangent, it's a perpendicular you draw on this line here, and anything which is anterior and distal to it, this bisection of this line is a shuttle point, which is approximate isometric insertion of MPFL. Remember, friends, we are creating a check rein. We are not really creating that same band of tissue. So there would be a minor variation, but anything within 9 millimeters of exact isometry is acceptable in the literature. So once you do that, now from the point where I had created that exit point for my hemostat, in the first stage when I was creating that tunnel. Now we create a tunnel from here, from the isometric point, from medial to lateral. For the sake of safety, when I'm creating this, I'm passing a bead pin again here. I usually like to direct my bead pin slightly proximally, angulated. And why I do it is because it's just that you want to avoid going close to the joint. And it doesn't matter which way the thread goes into the femur, because eventually the working area of your ligament is between the patella and the femur. The working area of the ligament is between your patella and femur. And then you over drill this particular bead pin again with a 9 mm reamer as being shown in this case. Once you've done that, you have to pass this graft through the femoral tunnel, as you can see. And all four threads of the graft of two threads from one limb, two threads from the other limb, which are coming from the patella, are passed and they come out from the lateral femoral condyle. And here you can see very clearly how it has come out very nicely. And now with this, holding the graft in hand, holding this thread in hand, we go ahead and do an arthroscopy to determine how much tension we are going to put in the graft. So even before we are going to fix the graft, I am seeing intra-articular how much tension is required so that I don't over tense the knee and I don't over tighten the patella on the medial side, which you can see here in this case I am doing. Now, once we have done this, we take our endo button. We have marked that area on the thread, and we take our endo button and we pass two threads on each side of the endo button. And it's a very simple, small implant, hardly costing anything at all. It can be, this surgery can be done anywhere and with any implant. You are not really at the mercy of any special implant. Once you do that, you put it on the lateral femoral condyle. You simply tie it, and again, after doing this, while you are doing it, you can do an intra-articular check. As you can see, now that tilt of patella completely goes away. Intra-articular, the patella slides very nicely. You can very nicely see how we have corrected the tilt of patella and the dislocation of patella on the lateral side. And there is no extra opening up. Once we have done this, we come out again and we do a closure, routine closure of the fascia with the superficial fascia of the patella. Once we have done this, we again go down and see how we have tightened up the patella. So we can see what we started off with. Now the patella hardly moves in that direction, but there is always some play. If you feel that there is too much of play, then at this stage, you still have a chance to do suturing on this part. So you can resuture your ligament to the fascia around the medial insertion of MPFL, so that the tunnel is redundant basically, and your ligament is retightened here if you actually want to do it after doing arthroscopy. If you don't want to do it, you can leave it alone as well. Now, this is not a true lateral Xray. This is the AP position, which is fine with me. The whole tunnel is quite away from the joint line. But at the same time, this is not the true lateral view, as you can see both the condyles. But this is a very satisfactory position. It is quite posterior, actually. Here we can see both the condyles, which we should not see in the X-ray. I'm sorry for this, but this is fine. I think this is the kind of X-ray which you get. And you can see how much thickness of patella on both sides is there. And you can easily get away with a 4.5 mm reamer also. Now, this is the clinical result after 3 months. This is the other side which has not been operated. Here you see how the leg she is moving once we do a bit of lateral test. But this is the operated side where she is quite comfortable and very stable, and she's not really apprehensive at all after the surgery. So this is the result, friends, and I think it's a very simple technique. In these times, which are difficult when we are not able to have meetings, I think this is the way we have to go forward. And this is a very simple and easy technique which has reproducible results in my hands. And I wanted to share with all of you. You can start off with this technique and you can see whether it works well or not. If you can do arthroscopy while doing this surgery, it's easy to find out how much correction you are making, and absolutely go ahead and do a final check even before you do the tightening of the implant, so that you can maintain the tension. And that's one of the good things about this technique. The second good thing is that you are hardly using any implant. which is, and you're not really screwing your graft inside the tunnel. So you are controlling the graft tension from the beginning to the end. Thank you very much.